So hello and welcome to today's webinar, Sleep Apnea and Cardiovascular Disease, hosted by Healing Hearts of Central Ohio and sponsored by Respicardia. We're excited to have such a large group with us tonight. Before we begin, I would like to remind the audience to feel free to submit questions throughout the event via the question and answer feature on your webinar toolbar. Our speakers will leave some time at the end of the presentation to address questions. Any technical questions you may have will be addressed as soon as possible. Our speakers today are Dr. Emani and Dr. Rosenthal, both of The Ohio State University. Dr. Emani is an associate professor of medicine at The Ohio State University with dual training in both advanced heart failure and cardiac transplant, as well as interventional cardiology. He also serves as the director of heart failure clinical research. His interests include device-based therapies for heart failure patients, including mechanical circulatory support, remote monitoring technologies, and other implantable technologies. He is a member of the sleep heart team involved in the treatment of CSA at OSU. Dr. Rosenthal is a pulmonary disease and sleep medicine specialist at OSU Wexner Medical Center. She specializes in sleep heart health, central and obstructive sleep apnea, chronic hypercapnic and hypoxemic respiratory failure requiring non-invasive ventilation, and COPD. She's the director of the Phrenic Nerve Stimulator Sleep Medicine Clinic and co-director of the Pulmonary Rehab Department. Finally, before we begin, I'd like to hand off to Jeff Davidson, the president of Healing Hearts of Central Ohio, to say a few words about his organization and mission.
Thank you. And I'm assuming everyone can hear me. Hello, and a special hello to our members and heart friends and sponsors who are listening. Thanks for joining us, and much thanks to Dr. Emani and Dr. Rosenthal. For those of you who don't know about us, Healing Hearts of Central Ohio is a 300-member heart support group based in Columbus. We visit patients in the hospital having open heart surgery and other procedures, and also host monthly educational meetings like this one. We've been doing it for about 10 years in the Ross Heart Hospital Auditorium until COVID-19. So trying to keep our doors open, if you will, we are in a Zoom mode for meetings until perhaps mid-2021. And as far as visiting patients, we're working with the Ross for on a procedure to either talk with patients over the phone or using FaceTime. And, you know, for many of you, when someone's had a heart event, dealing with AFib or heart failure or transplant, speaking with someone who's been there can be pretty reassuring. I've been on that end of the conversation, and it really makes a difference. So, and I'm also looking forward to this presentation, as many members of my family have sleep apnea, as well as diabetes and heart disease. And so sleep apnea education is very important. And then as a final note, I noticed that there were some healthcare professionals that registered, and if there's any hospitals in Ohio, certainly, that would be interested in setting up a large heart support group like ours, please contact me. Thanks, and back to you.
And Dr. Emani, you're on mute.
Let's try that again. All right, thank you everybody for joining us this evening, taking some time. Thank you, Jeff, for putting this together and having me back. For those that are Healing Heart regulars, I always appreciate the opportunity to spend some time with you, even in this virtual format. You know, today I start really with a broad introduction to sleep apnea, and importantly, because this is the Healing Hearts group, how it relates to cardiovascular health and cardiovascular disease. I am a consultant, and I do work with Respicardia, one of our sponsors for tonight's program. So I'm going to start off by saying, what is sleep apnea? And kind of more colloquial and maybe a little less definition-based. You know, sleep apnea is inefficient or inappropriate breathing patterns at night. And Dr. Rosenthal, far more an expert in this than I am, will hopefully spend a little bit more time going into some of the details about sleep apnea. But when we talk about this more broadly, think about a state or a combination of disorders where you may stop breathing for periods of time. And these are long periods of time, 10 seconds or more. That's a long period of time to not be taking a breath. Actually, now people, listening, just start holding your breath for 10 seconds. It's kind of a long time if you've ever been in a pool and you're trying to go underwater. It's not always just stopping breathing, though. Sometimes it's shallow breathing. It's the efficiency with which we breathe, and we're not taking good, deep breaths. And if this is happening at night, this can turn into a lot of problems, and we'll kind of go into that as we go along here. I categorize this, and it should be categorized in a broader definition of sleep disordered breathing, and really falls under sleep disorders. And there are a lot of things that start to become related as we go along. But for sleep apnea, and for our purposes here this evening, let's start by saying that there are two main types: obstructive sleep apnea, or what we often call OSA, and central sleep apnea, or CSA. And at times we can talk about these things as similar entities, and at times we do have to distinguish between the two, and it can be very important to understand the difference between the two, particularly as it comes to the treatment and the ability to positively impact our cardiovascular health. All right, so in my clinic, when I see you, you come into my office with your cardiac condition and I'm evaluating you. One of the things that I may ask you is, have you ever been told you have sleep apnea? And this should be fun. Here are the answers I get. Here are just a couple of the answers I get. I don't have trouble falling asleep. I sleep just fine, not to worry about me. Don't ask me about sleep apnea. I don't snore, doc, I don't. Or flat out, I don't have sleep apnea. So again, if I've seen a couple of you in clinic or your providers have asked you this, think about the response you gave. Was it one of these four? Turns out I get this a lot. Well, what isn't sleep apnea? I apologize for the catchiness of the slide transitions. Sleep apnea isn't necessarily about falling asleep. It's certainly not about staying asleep at times. Some people will tell me, once I fall asleep, I sleep all night long. I mean, I wake up later. Sleep apnea people, they're always getting up, right? It is about the quality and the efficiency of the sleep. Some people can fall asleep just fine, but they're not sleeping well. They're staying asleep, but they may not be sleeping well. And it's about the effects that this inefficient sleep pattern has on your body. This is important. This is what we focus on. So if we go back to these wonderful responses that I get when I first start asking about sleep apnea, I usually look at the patient and say, how do you know? You're asleep. How do you know you're not snoring most of the time? How do you know you're sleeping just fine? And if I really want to know what's going on, I'm going to ask a bed partner what's happening, because they usually rat it out. The signs and symptoms of sleep apnea, and this is not an inclusive list by any means. Sleep apnea can manifest in many different ways. But think about this in your daily life and your waking hours. Are you tired? Do you just feel fatigued? Do you feel drowsy during the day? And I'm not talking about that, maybe kind of after I had a big lunch type of drowsiness, but I need to sit down and get something done. I'm going to read a magazine, work on my computer, certainly, and I just can't focus. I'm doing one of these things over and over again. Do you feel like your brain is in a fog at times of the day? Like, I just can't think. Like, man, I really need to get this done, but it's just not happening. For whatever reason, I can't focus. One of the ways that I will often ask it is, do you wake up feeling rested? If I get a good regular night's sleep, am I getting up and I feel ready to take on the world, or do I still feel groggy and drowsy? And I'm not talking about people who aren't morning people, they're just angry at the world when they wake up, but I'm talking about true, like, I just don't have the energy to get up and start moving. Now, why would I, as a heart doctor, spend time talking about sleep? that's not really my expertise. Just focus on the rhythm and the heart attacks, dude. Just, stay in your lane, so to speak. Well, it turns out the complications of sleep apnea are numerous. Here's just a sample. As you can see, as we go across, heart rhythms, heart attack, heart failure symptoms, blood pressure, drowsiness, constant headaches, issues with obesity and trouble losing weight, the fatigue, impotence, for men who experience erectile dysfunction, this becomes very important. Memory loss, we all want to be a little smarter, at least I would think we do. Are these issues that plague us and would make us feel like we need to do something? Absolutely. And if you look at that top row there, these of course focus in what I do in the cardiology world and what, when you see your cardiologist, you're going to be talking about. Again, not to get into Dr. Rosenthal's territory, but we did briefly mention central versus obstructive sleep apnea. And just for quick review, sleep apnea, if I start with the definition that this is inefficient or ineffective breathing patterns at night, one of the questions is why? Why are we not breathing well? In obstructive sleep apnea, there's some sort of upper airway issue with airflow. That typically happens here in our oral pharyngeal lesion, the back of our mouth, throat, back of the nose, and up here in the upper portion of our airway. Central sleep apnea is more the signaling. And in order to stay asleep, it seems kind of easy, right? It's well, it's not brainless, as it turns out, but it certainly doesn't require conscious effort to fall asleep and try to stay asleep. But the brain still plays an active role. It has to send well-timed signals to the rest of your body to execute a breath and the oxygen exchange. It monitors your oxygen levels. It monitors your breathing rate and has to constantly make adjustments. It's a very complex pattern, and it's all mediated by your brain. And if those signals are not well organized and we're not conducting the symphony in the right way, you start to have inefficient breathing problems, and that's central sleep apnea. Now here I've labeled central sleep apnea in the center of the circle, but for initial purposes, this can be central or obstructive sleep apnea. And there's this vicious cycle that starts to happen. If I start at the top of the circle, we have apnea and hypopnea, which are fancy terms that we use to describe the quality of sleep and the patterns of sleep. Apnea is the absence of breathing, and hypopnea is slow, shallow, or ineffective breathing. And we're not breathing well, and we come around the circle, and that starts to cause hypoxia, which is a drop in oxygen levels. Now, sometimes this can also lead to changes in the quality or the depth of our sleep. We talk often about falling into a good deep sleep versus being in a restless sleep, which still may be a sleep state, but not where we want our brain waves and our energy consumption to be. So you start to come out of those nice, deep, restful sleeps. That can cause ischemia and inflammation. Again, words that we don't like in the cardiovascular word, right? Ischemia is another word for depriving the body of oxygen. Inflammation, of course, we know that that's bad. That increases sympathetic drive in our body. That sympathetic drive can then feed back and actually create more apnea. Now, what is sympathetic drive? Sympathetic drive is another way to say we increase our adrenaline levels. And adrenaline is generally a good thing, right? When I'm running away from a bear, right? I don't want my adrenaline levels really high at night. That's not when we want it to be. Turns out all of our mothers were right at some point, right? You need a good night's sleep. You need to sleep well. Turns out that our body does a lot of things when we're sleeping well. Restorative functions, reparative functions. We turn short-term memories into long-term memories. This is done by the absence of adrenaline. Our body shifts into a different mode of energy consumption and a different mode of being when we're in a good sleep. So if I've got adrenaline over here that's staying up even when I'm trying to sleep, I'm not doing well. In fact, adrenaline is what happens again when I'm running. If you've been sleeping all night, but your adrenaline levels are really high, your body has internally run a race all night long. And when you wake up, you feel tired because you've run that race all night long. So not good. Adrenaline not good when I'm asleep. And in fact, many of the medicines that we use to treat cardiovascular conditions, many of the medications that many of you are probably on, beta blockers like metoprolol and carvedilol, medications like lisinopril and Entresto for your heart failure patients, these are really, in some sense, anti-adrenaline medications, right? They're fighting the effects of high adrenaline. And in heart failure and in many other cardiac conditions, the adrenaline levels are already trying to be ramped up because of the abnormalities that exist in the cardiovascular system. I'm trying to bring them down with my medications, and yet here the body is fighting against what I'm trying to do by ramping the adrenaline levels right back up at night. And as one of my colleagues often says about these types of scenarios, you're pushing on the gas and brake pedal at the same time. We're not getting anywhere. Now, central sleep apnea, and this one is a little bit more specific to central sleep apnea as one of the subtypes, often comes hand in hand with cardiovascular disorders. And you can see on the pie chart here that patients who have any number of these cardiac conditions are at higher risk for central sleep apnea. And when we look at patients who have been diagnosed with central sleep apnea, we see over half of them have a history of active heart failure. When you add in atrial fibrillation, which is a big deal, right? Many of our known loved ones who have cardiac conditions suffer from atrial fibrillation. You can see that atrial fibrillation alone or atrial fibrillation in combination with heart failure starts to make up another major chunk of patients. Stroke, something that really is within the cardiovascular realm, and we want to prevent the devastating consequences of stroke associated with central sleep apnea. Other ways to think about it, right? So again, if you look at patients who have central sleep apnea, 70% or more of these patients have heart failure issues, or the other way around. If I have heart failure patients coming into my clinic, about half of them will have some degree of central sleep apnea. So when I ask this question, I'm going to be right either 1 out of 3 or half the time without even getting any more of a history. You're coming to see me in the office, you're at a high risk of central sleep apnea. Same is true if you're going to see your cardiologist or your electrical heart doctor about atrial fibrillation, right? 1 in 3 chance is pretty good just to start off. And then if you start asking some probing questions, you can start to find out patients who really have some other issues that clue you in to potential sleep issues. Again, in this illustration, we talk about central sleep apnea, but in this one, I think we're going to substitute obstructive at times as well. And it's another way to look at that wheel, this negative issue. But here it kind of gives you a visual of how it really cascades out. And if I take one diagnosis over here and I start to sweep across the screen, you can see how it explodes into many of the issues. And if you look at that purple column, these are the things we don't like: decrease in mental activity and increase in fatigue, increases in renin and heart rate and peripheral vascular resistance. These are things, that terminologies that we don't like as cardiologists. We want those arrows to be going down. Increased risk of dementia and stroke, as we talked about. And this is interesting, and probably again something that will continue to be explored. But high levels of inflammation over a period of time, we don't think that's good for the body. And this is why you get so much press about anti-inflammatory agents and things of that nature, because it may increase endothelial dysfunction, which is a fancy term for the fact that our inner tissue linings aren't working properly. And maybe this is related to certain cancer development over a period of time. So all bad things. Here again, this is more specific to central sleep apnea. We know from scientific studies that have been done that untreated central sleep apnea in heart failure patients leads to worsening heart failure outcomes. So you're 50% more likely to have an admission into the hospital. I mean, we like you guys. We don't want to see you in the hospital. We want to keep you out of the hospital. Twice the mortality rate. That's scary enough. I don't have to explain that more. Increases in the risk of other issues that start to make the treatment of the underlying heart failure worse, atrial fibrillation and other aspects. We talked about weight loss and difficult to control blood pressure. And really, at the end of the day, what does this all mean? It's a decrease in the quality of life. We're trying to improve our quality, and untreated central sleep apnea in this particular case can be a big detriment to that goal. In my world, heart failure, so I'm going to spend a little bit of time looking at heart failure. You can see the interplay between central sleep apnea and heart failure. These cycles feed one another. So the way to interpret this is to say patients who have central sleep apnea, when it starts to cycle poorly, actually makes the treatment of their heart failure worse. And it goes the other way too. If heart failure is not well treated, it can actually make the apnea issues worse. And you do have to think about these as intertwined as one and the same disease process at times. And this is why I will ask many of my patients at some point in their treatment course, what do we know about your sleep? Have we tested your sleep? We need to understand your sleep patterns better so that we can make sure we are treating all aspects of your cardiovascular health. So hopefully I'm harping on this enough, because I think treating sleep apnea is important. In obstructive sleep apnea, we have some data that shows that treating obstructive sleep apnea can improve cardiovascular function. For patients who have low ejection fraction, it may help increase EF to some degree. It may improve autonomic tone, which is something that we like. It's our reactivity and ability to react to different physiologic conditions. Now, this is to be done, treating the central sleep, or obstructive sleep apnea rather, is to be done in conjunction with the medications we use to treat heart disease. But when you put it all together, it can make a very positive impact. Now, treatment of obstructive sleep apnea is often done through positive airway pressure, CPAP, BiPAP, a mode called ASV. There are, again, several other things, and I know Dr. Rosenthal is going to spend a little bit of time talking about some of the other newer treatments available. But let's just start with the positive airway pressure, the PAPs, if you will. It is important to understand the type of sleep apnea that a patient has and what their concurrent cardiac conditions are, because you do have to match the therapy to the issues that are happening, both sleep and cardiac together. If you pick incorrectly, you can actually hurt patients. And an example is, a while back, we thought treating central sleep apnea with this fancy form of PAP therapy, ASV, may be good, and there were some initial studies that suggested it would be helpful. But when we really looked at that more closely, we found out that in some heart failure patients with central sleep apnea, ASV can actually make things worse. So this isn't just, one size fits all, everybody gets a mask. Also, one of the often things I hear, I don't want to wear one of those masks. Hey, if it's important, we'll have to work on the mask, but that doesn't mean it's the only way to treat it. I need to know what type of sleep apnea we have. I need to help really diagnose your heart conditions so that we can put this all together in the correct way. Here are some actual true scientific outcomes, and this is from one of the studies that OSU was a part of, where we treated central sleep apnea with a form of therapy called phrenic nerve stimulation. It's a wire that goes down to a specific nerve that stimulates your diaphragm to help you breathe at night. And you can see the green bars these are all the patients that got the therapy, and the green bars represent those patients that had some degree of improvement, both at 6 months and a year later. And you can see a vast majority of them, almost all of them, had some improvement. That isn't to say everybody does, and this is part of what we do when we treat patients. We have to try to identify those that may not do well, and there are reasons for that. But again, if we select patients appropriately, majority will do better, and these are quality sleep metrics that we looked at. So now hopefully I got you thinking, man, maybe I have sleep apnea. Maybe you're falling asleep during this presentation, and that may not be your sleep apnea. That may be me rambling on. But somewhere you might be thinking, I shouldn't have ignored them when they asked about it, or maybe I should ask about it the next time I go in. So let me give you a little primer here. So if you have symptoms of sleepiness and fatigue, yeah, let's get evaluated for sleep apnea. Do you have difficult to control heart rhythms? Are you coming back from multiple cardioversions or ablations? Might be time to think about sleep apnea. we know the success rate of cardioversions and ablations goes up if sleep apnea is treated and goes down if severe sleep apnea exists and is untreated. Are you kind of at a higher risk for a heart attack based on family history and cholesterol levels and other issues? Yeah, let's treat the sleep apnea. Are you at a higher risk for stroke because of family history and other risk factors? Let's treat sleep apnea. Do you have a history of heart failure and you still have some ongoing symptoms? You just don't have the energy, hard to move around, even some of those shortness of breath issues. Yeah, ask about sleep apnea. We're going to figure out where it belongs in your overall treatment. And very important, have you been in the hospital multiple times in the past year for heart-related issues? Again, the success rate of our heart therapies goes up if we treat sleep apnea, if it exists as well. So yes, you should be evaluated. So with that, I think I'm going to go ahead and pause here and probably turn it over to Dr. Rosenthal, who will give us a little bit more detailed information about the sleep apnea and treatments.
Okay, so give me 1 second and let me get our get selected here, or get my screen shared with you. And there is going to be a little bit of overlap, so I apologize with that, but and then we will get started here. Okay, so just to disclose that similar to Dr. Emani, I do also do a little bit of speaking and some research with Respicardia as well, who is one of the sponsors for tonight's talk. And so my area tonight, we're going to focus on just a little bit more differentiating between obstructive and central sleep apnea, which he did a great job touching on. I'm just going to touch on it a little bit more, and then we're going to really delve into the various treatment options for both obstructive sleep apnea as well as central sleep apnea. And I did leave a large amount of time for us to go through some questions. So hopefully when we finish my presentation, you'll have some good questions. And if not, then y'all can all enjoy the rest of your evening. Okay, so I just put this graphic up here to kind of create a visualization as to where we actually see the area of obstruction in patients who have obstructive sleep apnea. So when I talk to patients about obstructive versus central sleep apnea, one of the ways I like to differentiate it when describing between the two is I like to think of your airway sort of as a water hose. So if you think of your airway as a water hose and you think of an obstruction, you have the apnea, which is a complete obstruction of the airway. So a complete kink, or you say if you tied a knot in your airway, a knot in your water hose. Whereas a hypopnea would be that partial blockage in your airway, similar to this center graphic here, where you have about a 30% reduction in your airflow, and you have an additional drop in your oxygen saturation by at least 4%, okay? And then with a central apnea or a central hypopnea, the easy way to think about it, and I think Dr. Emani did a great job explaining that it's kind of I think he was talking about the, now I'm blanking on the way that he described it, but it was, the message wasn't really getting up to the brain as it should. So I like to think about it as the brain's not telling you to take a breath. So with obstructive sleep apnea, you have a kink in the water hose. Central sleep apnea, your brain's not telling you to take a breath. Of course, it's a lot more complicated than that, but that's sort of the easy way to think about it. And that becomes very important when we think about different treatment options, because with obstructive sleep apnea, we need to focus on opening up the airway. You are still trying to breathe. So your chest and your belly muscles are working hard to get a breath in. They just can't overcome that kink in the water hose. Whereas with central sleep apnea, we need your body to be told to breathe. So we need either a PAP machine, so a non-invasive ventilator, which I'll go through those devices, or the phrenic nerve stimulator to tell you you need to take a breath. And that is really the big difference when we're looking at treatment options for these two different categories of diseases. So first, looking at obstructive sleep apnea. And when we look at treatments for obstructive sleep apnea, it does vary upon your degree of severity of disease. With mild obstructive sleep apnea, if you don't have any comorbid conditions, then we may consider not treating you. And if you're listening to this talk today, you likely have some sort of comorbid condition because you likely have some sort of heart disease, whether it be an irregular heart rhythm or heart failure or a history of coronary artery disease that's bringing you here today, or cerebral vascular disease that's brought you here today. And so we would want to treat you. However, if you don't have any symptoms and you have a bed partner who complains that you snore, then we might say we could hold off for now. There are other options which we might use, and this would be kind of the medical management or behavioral modifications for the treatment of OSA. And this could be weight loss, treatment of nasal congestion, avoidance of alcohol, smoking cessation, avoidance of muscle relaxants, and sleep deprivation. So with weight loss and obstructive sleep apnea, studies have shown that with about a 30% weight loss, then you will have and that's from your ideal body weight, you will have about a 30 to 50% reduction in your apnea-hypopnea index. And so it's about a third and a third. So if you have a third of your weight loss, you can have about a third of your reduction in your apnea-hypopnea index. But that's not true with everyone. That really depends upon your upper airway structure. So the areas we typically see the obstruction are behind the level of your tongue and or your soft palate. So that's, the roof of your mouth ending in the uvula or the little punching bag in the roof of your mouth. So if you happen to have a lot of surrounding neck fat, then even if you lose a lot of body mass, but you still have a thicker neck, say if you're, looking at some of these football players who might not have a lot of body fat, but they have these thick muscular necks, they still might have obstructive sleep apnea despite losing some body weight. With treatment of nasal congestion, we might be using some inhaled nasal corticosteroids, which might improve some of your obstructive sleep apnea symptoms. With alcohol, muscle relaxants, and smoking, these all cause inflammation in the upper airways, which then cause increased turbulence, similar to nasal congestion, which can increase that obstruction as well in the upper airway. The positional therapy, so in some patients, we have what we call positional sleep apnea, in which when you sleep on your sides, your apnea-hypopnea index, or the number of events of total number of apneas plus hypopneas per hour of sleep that you have, is considerably less on your sides compared to your back. And if that's the case, then what we could do is try and treat you to prevent you from sleeping on your back. So in one study, 55% of patients who had sleep apnea only had positional sleep apnea. And this is what we define it as if you have 2 times higher position of apnea-hypopnea index in the supine position than in the non-supine position. So a couple of different marketable objects are out there, and they are ranging from $80 to I think $120 that you can buy online. But the cheap way that I like to tell patients is that you can just get an old t-shirt and a tennis ball, and you can sew the tennis ball into your t-shirt, and it's not very comfortable to roll on your back with a tennis ball there. Another option you can do is that you could have the pillows just around your back, And this could, oh, sorry, excuse me, my screen just went out of presentation mode. You could have pillows kind of bracing you so you won't roll over onto your backside as well. Next, positive airway pressure. So when I'm treating patients for obstructive sleep apnea, if we're going to treat them in any way, this is typically my go-to treatment. And although we'll be talking about a couple of other treatments that can be used in mild, moderate, or severe sleep apnea, one of the reasons this is the first line treatment is because it is the most effective. That is one. Another reason is because of cost. Of course, a lot of patients who they have concerns when they're starting to use a new device, it's not going to be comfortable, it's not sexy. I don't want to have to be, bound to some sort of mechanical device the rest of my life. I look like Darth Vader, whatever the excuse may be. But then once they start using it, they actually recognize that it might not be that bad. And I just put up here 3 different examples of CPAP devices, kind of the most common ones that are out there. So depending on the severity of your sleep apnea, when we start you with treatment, one of the ways that we can treat you is with something that's called automatic adjusting CPAP. And these devices are pretty neat because what we can do is set a range of pressures. So you might not have to go in to the sleep lab for a second night sleep study. And these devices will sense how many events that you're having, and it'll adjust the pressure to treat how much that it needs to give you. And so, and one thing that's neat about that as well is if you happen to have pretty significant positional sleep apnea, if you're on your side, you might require a CPAP pressure of say 6. And then if you're on your back, it might be a CPAP pressure of 12. And if you don't like that high pressure, then when you're on your side, you might not need that high pressure and the device will adjust for you. So it can be a lot more comfortable for the patients. And the newer devices are a lot quieter than the older devices. So people tend to like them a lot more. So I will say if you've had one in the past and you were not tolerant to it, it might be worthwhile to consider trying it again. Another option would be a mandibular advancement device. And these are just some pictures of different options of mandibular advancement devices. The way that these devices work is their goal is to essentially pull your lower jaw anteriorly to extend past your upper jaw. And this is to increase the diameter of your airway anteriorly to posteriorly. So it also will cause the airway to become more tight or taut, so it will not collapse as easily. These devices work really well in people who have mild sleep apnea. In fact, studies have shown in patients who have mild sleep apnea, they work almost as well as CPAP. The one reason I typically don't recommend this as first line is because of cost. A lot of insurance companies will not reimburse this first line. Plus, if you get it because it's custom made, it's not like you can give it back. Whereas with CPAP, it's on a rent to own basis. So if you're wearing it and you just say, okay, I really can't tolerate the CPAP, you can return it to the medical equipment company. You've lost, say $60 rather than maybe $600, which might be the cost of the oral appliance. Plus, once you get the oral appliance, insurance typically won't let you get a CPAP for an entire year, despite you not tolerating the oral appliance. Now, if you decide to go to the oral appliance route, I would also recommend that you go to a dentist who is certified by the American Board of Dental Sleep Medicine. There are a lot of dentists out there who say that they make these devices, but they might not be specialized in ones to treat sleep apnea. There are some that just make devices for snoring and they might work well, but they might not follow you as closely or know how to do the correct assessment for analysis for treatment of obstructive sleep apnea. Now, here is just a graphic representation of what the mandibular advancement device does. So you can see on the graphic on the left that where the airway, you see the blue air is supposed to be going, and the red, the airway is closed behind the level of the tongue. Now, when you have the mandibular advancement device in place, the jaw is going to be pulled forward, and it's very, very small amount. I mean, millimeters, but it's enough that it actually improves this obstruction and it allows air to pass all the way down through the airway to reach the lungs. Next, we have surgical options. This is really my last line of treatment. And the reason I say that is because these treatment options, can be, I guess some of them now are more moderately invasive, but they're not nearly as effective as CPAP, oral appliances, or the hypoglossal nerve stimulator, which I will talk to you about last. The surgical options, they are also pretty painful, and they tend to only improve your apnea-hypopnea index between 50 to 70% from baseline. So if you have very severe sleep apnea, say your apnea-hypopnea index is 70, and you get a procedure done, you still will have severe sleep apnea. One example of the most aggressive surgical procedures is called a UPPP. And what they do is the surgeons will go in, they remove your tonsils, they remove your uvula, they remove part of your palate, and essentially this is what your airway is going to look like. With removing all of this redundant extra tissue, it allows the airway to be more tight, and it prevents this extra tissue from collapsing. So some patients will have an initial response that they'll do really well, and then a few years later, their sleep apnea will return, not respond, I apologize. Next is another newer surgical procedure is a hyoid and tongue-based suspension that we do at Ohio State, which essentially they put in a small wire which pulls the tongue as well as the hyoid bone anteriorly. And again, this will be increasing the airway diameter as well. It's a very quick same-day operation, outpatient procedure. It tends to be very painless, minimal complications, has a little bit more of a response than some patients do with the UPPP. And it is a newer procedure compared to some of the older surgical options. So if you are very hesitant to doing CPAP, it could be something to consider, which it might even improve your obstructive sleep apnea severity. So if you're pressure intolerant, meaning you can't tolerate the higher pressures, then maybe with this and then considering CPAP at a lower pressure, you'd be able to tolerate that. The last thing I'm going to talk about for treatment of obstructive sleep apnea is the hypoglossal nerve stimulator. So this device is a small stimulator which is inserted under the chin. Your ear, nose, and throat doctor dissects down into the hypoglossal nerve, which this nerve is responsible for causing the tongue to move forward and backwards, rolling the tongue and moving it side to side. And one of its branches actually can be isolated, and that's the branch that causes the tongue to stick out or protrude. And this is the tongue that we try to isolate to allow the airway to open up and stimulate to improve and treat obstructive sleep apnea. So the way that Inspire which is the only company that is FDA approved in the US for the hypoglossal nerve stimulation. So as I said, you have an incision that's under your chin here. They dissect down to find the hypoglossal nerve, and then they will attach a little stimulator device onto the portion of the hypoglossal nerve that causes the tongue to protrude or stick out. Then they'll tunnel this lead to a little generator, which will be under your chest, similar to if you have a pacemaker. It's a little bit larger than a pacemaker. And then there's a sensing lead that's tunneled under the skin, which will be sensing when you're trying to take a breath in. Now, what's interesting about this device is that it has a remote control, which is a lot smaller than this, that you set it on top of the generator, which you will turn on the device when you're ready to go to sleep. When you are first using the device, you'll be able to have control of the stimulation. So you'll be basically adjusting the stimulation yourself into the power that you need and you can tolerate. And then you'll go in and have sleep studies to ensure that you're getting adequate treatment to control your obstructive sleep apnea. And this device has been shown to improve obstructive sleep apnea and the apnea-hypopnea index by 90%. So it's also a very effective device. The criteria for Inspire is your age. You have to be greater than or equal to 22. Your apnea-hypopnea index, you have to be moderate or severe with less than 25% of central apneas. Your body mass index has to be under 32. And what we mean by complete concentric collapse. So when you look at the airway on a procedure called a drug-induced sleep endoscopy, we will be looking to see how the airway is opening and closing. So if the airway closes front to back or anterior posteriorly, then you would be a candidate for the device. And this is because if we stimulate that hypoglossal nerve and we cause your tongue to pull forward, we'll be able to open up the airway. However, if you have what we call concentric collapse, or if you picture your airway opening and closing like a camera shutter, then if we pulled the tongue forward, it's not going to do anything because your airway is still closing circumferentially or more in a circular manner. So you would not be a candidate. All right, so now moving on to central sleep apnea, which we don't have nearly as many options, so it's not going to be as long-winded of a talk. So as we went through, we have all of these different options when we talk about obstructive sleep apnea. The one thing I did not talk about when we're talking about surgeries for treatment of obstructive sleep apnea is tracheostomy. And that's really our last line treatment for obstructive sleep apnea. And that's when we create a surgical airway and basically a hole in the trachea below the level of obstruction, which that's our very, very last line treatment option. When we're looking at central sleep apnea, we don't have many options that are actually FDA approved for central sleep apnea. A lot of different studies have looked at what could be used to treat central sleep apnea, and we had really bad outcomes. Dr. Emani had mentioned a little bit about adaptive servo-ventilation, or ASV, and how the study went in and looked at patients with heart failure, and we had bad outcomes. And I'll go into that in just a minute. The only other device that has been FDA approved is the phrenic nerve stimulator, or remedē, by a company called Respicardia, which is one of the sponsors for tonight's talk. So going through just a couple of the topics. So these are predominantly looking in patients with heart disease. And one reason, of course, I'm focusing on this is because we are in a heart talk today. But as Dr. Emani pointed out, the majority of our central sleep apnea patients are patients who do have heart disease. So one of the studies that looked at the patients who had used CPAP to treatment for patients with central sleep apnea, they had higher mortality. So you're going to be seeing higher mortality in a lot of these different treatment groups. In the adaptive servo-ventilation group, so this was the SERVE-HF trial, which was a very large trial, 1,300 patients who had heart failure with a low ejection fraction, meaning they had very poor squeeze in their hearts. They had very, very poor outcomes, increased mortality. And so this study was actually ended early, and there's a black box warning put on this device. Now, there was another study that was completed, which actually showed there was increased benefit in patients who did not have a low ejection fraction. So we can actually use the adaptive servoventilation in patients who do not have heart disease, whose ejection fraction is above 45%. So if you have central sleep apnea from the use of opiates or some sort of other neurologic condition or primary central sleep apnea, then we are able to use that device. There are a couple of medications that have been trialed to treat central sleep apnea. And again, these also were not safe to use in patients with heart disease. Risks for arrhythmias were a big consideration in patients with heart failure. And then one study that is still ongoing is using oxygen in patients. And one of the things that we're very concerned about in patients with heart failure, again, is actually high oxygen levels might be more harmful to patients who have heart failure. And again, in these smaller studies, it really didn't show any improvement in patients' quality of life. So there was no improvement in their daytime sleepiness or their arousals. So the phrenic nerve stimulator, as Dr. Emani said, what the phrenic nerve does is it is the nerve that stimulates the diaphragm, which is our muscle that helps us breathe. This muscle is our lifeline. If our diaphragm isn't working, we can't breathe, okay? And so some people, what happens is when we're sleeping and we have central sleep apnea, the brain isn't telling the diaphragm to function. And so what the phrenic nerve stimulator does is it actually, while we're sleeping, it is going to innervate that phrenic nerve and have the diaphragm move while you're sleeping. And what's really neat about this device is it's not going to be active when you're awake, when you're sitting upright. It's going to be activated when you lay down. It's going to sense when you lay down, and it's going to pull your diaphragm, and it's going to work just as though you're taking normal breaths. And the patients that have this device are very comfortable with it. The side effects from getting the implantation and the complications from the implantation are very minimal. The way the device is implanted, it's actually done by electrophysiologists, similar to if you've had a heart catheterization or any electrophysiological procedure in the past. They will go in through one of your groin veins, and then the battery pack is placed, or generator is placed on your chest, similar to a pacemaker. And so it is a fantastic option if you do have central sleep apnea. And Dr. Emani did show you the results of the studies and how effective this device is. So just to show you a little bit of what the device looks like when you have the pacer turned on. So on the left here, you can see, this is kind of a graphic representation of what your study, what it would look like if you were having a sleep study. So the top is your oxygen saturation. You can see it kind of be normal, then it drops, then it gets high again, and then it drops, and then it gets high and it drops. And this is corresponding with the movement. So you're having, when you see these up and down, this is corresponding with your breath. So this is your chest and your belly moving. So when you're taking normal breaths. This is corresponding with your nasal pressure or your airflow. So you can see here with your airflow, when you're breathing in, out, in, out, in, out, and then you have this flat line where you're not breathing. When you're not breathing, you have no airflow or no movement of your abdomen, no movement of your chest. And what's interesting with central sleep apnea is you might be a little bit confused and say, wait, you see your oxygen dropping when you're still taking breaths. Well, because when we usually see this central sleep apnea in patients who do have heart failure, we have this kind of delay in what we call our circulation time, or oxygen and blood getting around the body. And so by the time this low oxygen level, low blood level gets to the oxygen monitor on your finger, it's already when your breathing has started again. It's just because the blood flow circulating around your body is slower. So that's why you can kind of see this lag. Now, once we have the device turned on, you can see that all of these things normalize. Your oxygen normalizes, your breathing pattern normalizes, the movement of your thorax and your abdomen normalizes. I just find it really remarkable. It's a really beautiful picture and just fascinating device. So as you can tell, I really love it. Anyway, that is the end of my presentation. And I think it looks like we've got some questions here. So I think Seamus was going to help us go through some questions.
Yep, thank you, Dr. Rosenthal, and thank you, Dr. Emani. Those were both fantastic talks. We really appreciate you sharing all that information. We have had quite a few questions come in, so let me just start rolling with those. So the first is for Dr. Rosenthal. You mentioned some behavioral modifications that you can make for OSA. Do things like weight loss help with central sleep apnea as well?
So that's a great question, and unfortunately, no. With central sleep apnea, because it has more to do with the body's, the kind of brain's control telling you to breathe and not a mechanical obstruction, weight changes will not affect it.
Okay, thank you. And the next question also for you is, how do you treat people with both central and obstructive sleep apnea?
So that's another great question. And it really depends upon the etiology or I guess the cause of the central sleep apnea. If it is related to heart failure, it depends on how severe the heart failure is as to what treatment it can be. If the ejection fraction is greater than 45%, the adaptive servo ventilation is a wonderful treatment option. If it is less than 45%, one of the ways that we could consider treatment would be with a BiPAP ST, which is a BiPAP device which has a backup rate, meaning that it will ensure that you're getting a certain number of breaths per minute in addition to the positive airway pressure support. Those are, I mean, I would say those are my first line treatments. Sometimes we can get a little bit more creative depending on when we're looking at the percentage between, if you have, you know, some patients might have severe central sleep apnea, but mild obstructive sleep apnea. And in those cases, I have had patients get the phrenic nerve stimulator implanted, and then we might have to treat the obstructive component after that they've been implanted. Other patients, it might be the other way around, where they have severe obstructive sleep apnea and mild central sleep apnea, and if they couldn't tolerate, you know, CPAP, then they would do the hypoglossal nerve stimulator, and then we might, you know, treat them with oxygen or positive airway pressure for the central sleep apnea component.
Perfect. And the next question, and really this could go to either of you, so feel free to jump in, but is there research that shows central sleep apnea actually causing cardiovascular conditions? And is there a need to screen for CSA before cardiac conditions emerge?
Yeah, I can start with that. And, you know, I think the link between the two disorders is strong, but at the same time, you know, in our initial studies, there are about 14% of patients that had central sleep apnea with no recognizable cardiac disease. I would consider those patients at higher risk of developing cardiac disease, but I don't think it's caused by the central sleep apnea directly. You know, I think though it's a risk factor, and it ends up interplaying with other risk factors that a patient may have to develop their heart conditions, and the perfect storm may arise. So that being said, I think if you have symptoms of sleep apnea independently, the daytime fatigue, the napping, you know, maybe some of the memory loss or other issues, certainly get screened and treated for the appropriate subtype of sleep apnea. But if you're doing this as part of a population health-based strategy to prevent cardiovascular disease, I don't know that we need to be upfront and say, hey, if I treat, because there's also no evidence or no data to support that if I treat their central sleep apnea, I'm going to prevent their progression to cardiac disease. Any thoughts, Dr. Rosenthal?
I mean, I would say that in the sleep world, there are a lot of debates in regards to this. There are some people who really feel that central sleep apnea might be overtreated, and other people that say you have to treat central sleep apnea aggressively. And I don't think we have enough literature really, or research, to say one way or the other whether it could cause the cardiovascular conditions or not. I think Dr. Emani answered it very well, and I think that's more research to come, to be honest, on it in the future.
Sounds good. And the next question is a two-parter, but can you talk a little bit more about the process of getting tested for sleep apnea, and how reliable is the diagnosis between central sleep apnea versus obstructive sleep apnea?
Sure. I think I'll take this one, Ramesh.
Sure, yeah, please.
So there's two main ways that we can test for sleep apnea. So there's the home sleep study and then the in-lab sleep study. The home sleep tests, and there's different types of home sleep tests, and I'm just going to go through kind of the most common types that we use here in our sleep labs. And with the home sleep tests, they are validated to diagnose obstructive sleep apnea. They're not validated to diagnose central sleep apnea. They can also diagnose, rule in, rule out sleep apnea in general. The reason is because when we are evaluating obstructive versus central sleep apnea, as I tried to show a little bit in that last picture, we need to look at the abdominal and the thoracic belts, as well as the nasal pressure flow, as well as what really helps us is the EEG monitoring, looking at your brainwave activity. Because what's interesting, when we are sleeping, when we're awake, we can have what we call these post-arousal sighs. So even when you think about it right now, if you were to take a big breath in and you sigh, you'll have a pause in your breathing afterwards. And this is a compensatory pause where basically your breathing control center is being reset. And this happens the same when you're sleeping. When we're looking at a home sleep apnea test, since we are not monitoring your brainwave activity, we can't necessarily tell when you're awake and when you're asleep. So you might have one of these arousals and then have a post-arousal sigh. And we can't necessarily say, is this a post-arousal sigh or is this a central sleep or a central apnea? And so what happens is we might score it as an apnea. You might look like you have central apnea events, but we can't 100% say that you have central sleep apnea because it could be all of these post-arousal sighs. So if we want to definitively say, are you having central or obstructive sleep apnea, we need to do an in-lab sleep study. Now, to complicate that a little bit further, we have hypopneas. And if you remember, the hypopnea is the partial decrease in airflow and the drop in oxygen saturation. So with a hypopnea, to differentiate between an obstructive and central hypopnea, the way that we should do it, which no one does except in pediatric sleep labs or in research labs, is to put an esophageal pressure monitor. And basically the reason we do that is because you need to look for effort. So are you trying to take a breath in? We don't do that. So how else can we determine it? The way that you can kind of evaluate for it would be if you're snoring. If you're snoring, we say that you are likely having an obstructive hypopnea. Now, because this is so nuanced, a lot of sleep labs don't really go down and differentiate between obstructive or central hypopneas. And so when you get a sleep study that says you have severe central sleep apnea or mixed obstructive and central sleep apnea, and you're trying to decide if you want to do a stimulator treatment, you just can't tolerate PAP therapy, I would recommend having more, repeating a sleep study with someone who really will go through and count how many obstructive and central hypopneas you're having. And I could be very OCD and that's what I do, but I just don't want to give someone a device, implant them with a device and have it not work. So that's my long-winded answer for talking about the different diagnoses. Sorry, hopefully I answered multiple questions with that.
You did. No, we appreciate it. I think the detail's helpful for people. It's tricky to figure out. The next question came about both remedē and then about Inspire as well, which is if I have a pacemaker or defibrillator, does that cause any problem with getting the sleep apnea devices?
No.
Short answer.
I don't know.
No. Short answer. No. Agreed. In fact, in our at least the remedē data, which I'm more familiar with, many of our patients had a concomitant device, and it is designed and tested to make sure there's no interference. So it is in my general quest to turn you into a bionic person, to put as many devices into you as I can.
It's the same with the Inspire data. We obviously, with the Inspire patients, there were not nearly as many in the pilot or pivotal trials who had defibrillators or pacemakers compared to in the remedē or Respicardia trials, but they did not see any contraindication to having both devices. Just one on each side.
Yeah.
Perfect, thanks.
Yeah, how many shoulders do you have? I can keep putting devices in you if you want.
Okay, then the next question, again, it's a couple different questions we got, but it's about the therapies that must be tried and failed before getting either Inspire or remedē. So the question is, do you have to try mass-based therapy before getting remedē? And same thing with Inspire.
With Inspire, yes. You have to try and fail CPAP. That is definitely one of the caveats. With remedē, did it just change that you don't have to have failed? I think it might still be insurance dependent. Seamus, you might know the answer better than me on this.
Yeah, it's so it can be insurance dependent. It's approved as a first-line therapy, but as you know, Dr. Rosenthal, there are definitely clinicians that will want to use other things first that are less invasive.
Yeah,
okay.
that's kind of been my experience, is that patients who they tried it doesn't even have to be, you have to try it very long. It can be a very short period of time that you've tried the device and you don't like it. The insurance companies don't keep track of the time course of how long you've tried the device.
Okay, thank you. And I know we're kind of getting past the time here, so I'm just going to take one more question. So let me ask, so a good one to end on here maybe is, do you have any advice for people who are not wanting to get their sleep apnea treated or who are in denial about their sleep problems?
You go first, please.
So is this coming from the patient or coming from the family member, I would say, or the physician? Because I think the advice, it varies. What I always like to say to my patients is, we can start small, right? So the first thing, we can always do is we just have to look for it, right? It doesn't mean you have it. So if we first start by we can even look by, so sometimes if patients are very hesitant to evaluate, I'll even start with doing an overnight oxygen study, which is very easy to do. It gets sent to your house, you sleep with an oxygen monitor on your finger. We can look and see if your oxygen is varying during the night. Even if your oxygen isn't dropping significantly during the night, I can see different patterns which could guide me, well, you might have sleep apnea, and I think we need to move to the next step. So I think it's really taking a personalized approach to each patient. And then if we find you have sleep apnea, to really go through our different options and think about what we could do for treatment, right? Sometimes I think the hardest thing is when a sleep and the very first visit about the comorbidities, the how we diagnose it, how we treat it. It's a lot, and it's scary. And people, you know, see friends who are, you know stories about people wearing CPAP, or were in the hospital and had, you know, BiPAP thrown on them when they were in the hospital, and they had terrible experiences, and trying to just reassure them that it can be a better experience than that. And I really try to work with patients early on, and just be there for them if they are hesitant early on. So I think that that is all you can do, is just try and be there as much as you can for the patient, and to have them understand the importance of why I want to do it. Obviously, I can't force someone to do it if they don't want to, but really for it to be their decision, and they can always reach out to me later if they change their mind. Ramesh? Dr. Emani, sorry, I'm calling you by your first name.
Yeah, no worries. So I think, you know, one of the things that comes down to, right, it's a lot. And, you know, we do acknowledge that there's a lot of stuff coming at you, particularly, you know, oftentimes the diagnosis of sleep apnea comes hand in hand with something else that's been going on. And many providers, many angles coming at you. Here are a bunch of new medicines. Here, you got to exercise more. You need to lose weight. You need to change your diet. And by the way, please, you know, strap this on your face, or please, you know, it is a lot. And like all treatments that we recommend, I think the key to all of this is asking a question, you know, how is this going to help me? What is the expected benefit for me in my particular situation? And sometimes there's a timing aspect to this as well. You know, on the heart failure side of things, a lot of times, you know, it's probably important to treat the heart failure to a good degree before we really delve into the sleep aspects of it, because the settings, as Dr. Rosenthal alluded to, you know, if it's a mass-based therapy, the settings may change if I do a better job of treating you and getting extra water off of you, if I treat your blood pressure better. On your side, if you're committed to making lifestyle changes and you know, exercise more and you lose some weight, and you know, there's a whole aspect that the sleep hygiene that, you know, we could touch on, but is, you know, important. You know, you're not taking caffeinated beverages and you're cutting out your alcohol. It's going to change how we treat things. So, you know, my short aspect is oftentimes, although I may ask about it at the get-go, if this is a new cardiac diagnosis, I actually want to see how you do with the treatment of the cardiac stuff more directly, and then start to look at the sleep. And, you know, some of that may help. So it may not necessarily be pure denial as much just being overwhelmed. And I think it's a fair thing to ask, you know, what's the right sequence? How should I layer these things on top of each other before I get everything thrown at me?
I think that's a great place to leave it. Thank you, Dr. Rosenthal and Dr. Emani. Fantastic presentations, and I think we had a great Q&A as well. We do have more questions rolling in, and for everyone that asked those questions, we'll do our best to follow up after the fact, but we appreciate all the attention, and great session overall. With that, let me hand it over to Jeff, who I think wanted to say just a few words in closing. And Jeff, you're on mute.
There we go. Sorry about that. Thank you very much. And Dr. Emani and Dr. Rosenthal, incredible presentation, as always, and such an important topic. I'm learning so much about the interaction, sleep apnea, diabetes, heart failure, and everything. So many different diseases are related. So urge everyone to get the sleep apnea issue checked out, especially if your wife's complaining about your making loud noise during the night. So thank you very much.
Y'all are very welcome. It was my pleasure.
Yes, thank you guys. Thank you for your time this evening.
Thanks everyone. Have a good night.